Hello, everyone, and welcome to our webinar series meeting the opioid challenge in the emergency department. This is our first session out of 4. Today's session is titled How to Meet the Emerging Standard of Care of OUD Care in the ED. Some quick webinar housekeeping or logistics. All participants will be muted. If you have any questions throughout any point in the webinar, please feel free to just drop them in the chat, and we will review them and have a couple times throughout the webinar to review those questions and answer them. If you have any issues with the chat feature, please feel free to submit questions to me through that email, and I'll drop that in the chat as well for you all. And stay at the end to hear about evaluation and CME approval, as well as a Q&A. And I will pass along to our CEO, Alyssa Bassler.
Thank you, Samantha, and welcome everyone. Can you change the slide, please? Welcome to everyone to the webinar series. Very excited about having your participation. Steve, are you there? We go.
Yeah. Yes.
And you know, technical. Well, here we are anyway, so we'll keep this going and going. So I wanted to just give a little bit of background about the program that this webinar is a part of, and the work that we've been doing. So we've been partnering, the Illinois Public Health Institute has been partnering with the Chicago Department of Public Health for the last several years on work to advance participation of emergency departments in the opioid response and treatment system. So we're working to increase emergency departments' capacity, in particular focusing on dispensing naloxone to patients at risk of overdose, initiating medication-assisted treatment in the emergency department with referrals to community-based treatment providers. We did some work a few years ago on legislation and policy to get Medicaid reimbursement for that service, and then also on connecting people with opioid use disorder to immediate medication-assisted treatment support through a statewide initiative called MAR Now, or Medication Assisted Recovery Now, which is you'll hear a little bit more about how that might work for you. Next slide. As part of this, in addition the work of capacity building, in addition to this webinar series, we have a consultation program continuing through the summer, where you can schedule a brief consult with one of the physician leaders and subject matter experts that you'll see on this webinar today, to figure out what you might need in your emergency department, do a customized presentation with your emergency department on opioid response, and then potentially one-on-one consultation on any aspect of that work that would be helpful to you, including strategies like policy development or developing workflows. So that is available, and I think we'll see Samantha's 2 emergency departments, and I think we'll see Samantha's emails at some point in this presentation, and you can always write to her to get scheduled to be part of that capacity building work. And Samantha, it looks like, has also put it in the chat. Next slide. So CMEs are being offered through the University of Illinois College of Medicine for this program. And if you stay on at the end, there'll be information about how you get those CMEs credited to you. Next slide. So this series, there's 4 webinars in this series. So today we're talking about meeting the opioid challenge in the ED in general. On June 23rd, we're going to talk about stigma and bias in opioid treatment and how to overcome that. It's a huge barrier to people getting the care that they need. And then in mid-July, more detail on technical aspects of opioid treatment and response in the ED, and then finally some work around collaboration, referral workflows, and payments at the end of July. So we're looking forward to all of those, and we're excited to have you on this one, on this first webinar. And hopefully you'll join the others and tell other people to join them. Next slide. So I'm going to turn it over now to our presentation team. So I'll hand it off to Dr. Richardson, who will introduce herself, and everybody, these folks will all introduce themselves, and then we'll go from there. So thank you very much.
Thanks, Alyssa. I'm Dr. Jess Richardson, family medicine, originally working at federally qualified health centers in Chicago, and then came across a multitude of patients who have substance use disorder, really started my practice with addiction medicine, and then became board certified in addiction medicine as well. Now I'm the director of addiction medicine at Near North Health, and I'm really glad to be here. I'm going to go ahead and pass it over to Diana.
Diana Patari. I am the medical director for controlled substance monitoring training for Advocate Aurora Health. I'm board certified in addiction medicine, integrative medicine, and pediatric medicine. I have a medication assisted treatment on the south side of Chicago. I became very passionate, basically because I felt that these poor patients were not being taken care of as well as I thought we could as a healthcare organization. And so I was very happy to get involved with Illinois Public Health Institute to spread the word and work with these fabulous people.
And my name is Steve Holtzberg, and I was an ER doctor at Del Nor, which is part of the Northwestern system, for 23 years. And 5 or 6 years ago, when the overdose crisis was sort of completely out of control, although it's more so now, I started to become interested in addiction medicine and started to treat patients with buprenorphine for opioid use disorder. And I sort of really became intrigued and hooked on addiction medicine. It was just very fulfilling work. As Diana mentioned, like there wasn't treatment available. I was meeting patients that just really needed treatment. And then once you started to treat them, lo and behold, they got better. So I underwent, several years to kind of extricate myself from the ER. I studied addiction, took the addiction boards as well. And now I am doing strictly addiction medicine. I haven't done an ER shift since late 2021, and really couldn't be more fulfilled in my work life. However, kind of once an ER doc, always an ER doc. So one of my interests is really trying to improve the care and build capacity within the ERs to treat patients with substance use disorder, and most specifically opioid use disorder. So I really appreciate everybody taking time out of their Friday to listen to this talk, one of 4 in the webinar series. So thank you very much for being here. So my ask is, or my proposal is, that emergency departments should do these things. And I realized, being an ER doc myself, that the emergency department is often asked to do many things that may not be perfect within their expertise. But I am here to tell you that this is not one of those things. The emergency department is in the perfect position to do these things. And that is, number one, dispense naloxone to patients at risk for overdose. You notice it says dispense and not prescribe. We know that just a prescription for naloxone has a very low chance of actually being fulfilled, certainly less than 10%. Also, I think emergency departments should initiate and prescribe buprenorphine to patients with moderate to severe opioid use disorder. It's not hard. It's really very easy, and we will. There's much support available. And finally, a key piece is arrange treatment or a warm handoff within the community. This has really been a barrier in the past. Several years ago, it was hard to find somebody to take the patient in the community. The situation is much better now, and we'll talk about that. And I think it will continue to improve. All right, so why the emergency department? Well, plain and simple, this is where the patients are. patients with opioid use disorder end up in the ED, and they end up in the ED for a whole host of reasons. Not only overdose, but they end up there with cellulitis, with an abscess, with mental health issues, suicidality, trauma. So we are open 24/7, and we really should be in a position to take care of these patients. And here is a patient of mine in long-term recovery, and this is what she says about emergency department prescribing buprenorphine.
You're giving them a gift. Like, maybe they won't make the right decision, but if they're like me, like I said, the first time I took it, I don't remember if it was like right away that I got on this path, but in the back of my mind, I always knew that was there. And then the second I was ready, like, I found a doctor. I mean, I made it happen. So why wouldn't they want to give that option to, any other patient that comes through the ER?
That's right. You're giving them a gift.
You're giving them a gift. Like,
all right. So this really is the work of the ED. I hope that I can convince you all. And I think probably if you're on this call, you are an advocate of this. If you are doing this in your ED, congratulations. We love it. We would just ask that you spread it. Talk to your friends. Talk to your ER down the street. Tell them how easy it's doing. I love the fact that people are doing this. If you're thinking about it, I hope that we can nudge you to do this work. And if there are any naysayers on the call that are still holding on to, this is not the ER's job, these people don't get better, I'm not interested, we hope to get you off of that spot, because it really is the work of the ED. This is a op-ed from the New England Journal of Medicine. Emergency department's a 24/7, 365 option for combating the opioid crisis. And these authors write, by thinking of the ED as an integral part of the response to the opioid crisis, we can help change the trajectory of the epidemic. And this was written in 2018. I remember when this came out, and it was really, I thought about it and I thought, yeah, we need to be doing better. We're always open. This is why we went into this specialty, to be ready whenever we're needed, and we are needed at this time. So this is an editorial from the Annals of Emergency Medicine, written by an ER doc from the CDC and Dr. Jerome Adams. If you remember, Dr. Adams was the Surgeon General in the last administration, and he was actually very strong on this issue. His older brother battled substance use disorder for years and was incarcerated and may still be incarcerated. So they write, emergency physicians have been and always will be the all too necessary safety net for many, an especially important partner in combating the opioid overdose epidemic. We cannot become complacent. America's patients and communities need emergency physicians to redouble their efforts, challenge their colleagues and institutions to do more, and partner to work upstream now more than ever. It really is true. I think that it's difficult for the bedside sort of pit doc to make institutional type change, but I think this is a case where we really need those of us that are those of you now that are at the bedside really need to talk to your ED director, CMO, C-suite folks, and really get this going. So, and it's not just the CDC, it's not just the Surgeon General. Our organizations also are asking us to do this work. This is AAEM, the American Academy of Emergency Medicine. In mid-2019, they came out with a white paper about the management of OUD in the ED, and it's talking about the same things about buprenorphine, warm handoff, and dispensing naloxone. In addition, this is the American College of Medical Toxicology. They have a position statement where they support the administration of buprenorphine as a bridge to long-term treatment and support the use of buprenorphine to patients in opioid withdrawal. So it's essentially, it is unanimous. So And finally, this is an important paper. This is from the American College of Emergency Physicians, the section on pain and addiction. They came out with consensus recommendations on the treatment of OUD and the ED. This is about a year and a half ago. It's a wonderful document, easily readable. There are 80 references. I strongly encourage you all to download it, print it, and give it to your partners within the ED. All right, let's talk a little bit about the impact that we can make and just how serious it can be when patients with overdose come into our ED. This is a famous study from a few years back, 1 year mortality of patients after treatment for non-fatal overdose. So this is in Massachusetts. Massachusetts is actually got a robust health system, solid public health infrastructure. And this is from 2011 and 2015. There were about 17,000 patients with non-fatal overdose. And they just tracked them for a year retrospectively. What happened to those patients that had non-fatal overdose? Well, 5.5% of them were dead within 1 year. And that 5.5% 1 year mortality is about the same as a heart attack. So, we're talking about a very morbid diagnosis. And of course, these patients are younger than patients that have a heart attack. So 635 of them died. And interestingly, the deaths were really front loaded. So 130 of those patients, 20% of those patients, died within the first month. And then 20% of those died within the first 2 days. So I think it speaks to the fact that if patients that come to the ER with non-fatal overdose are really not doing well, I think they're really not doing well, and they're at significant risk for death soon after that ER visit. So, and 67% of those people that did die died from overdose. So because you might expect it to be close to 100%, but patients with opioid use disorder die from a whole host of reasons. They, of course, die from overdose, but they also die from infection, sepsis, endocarditis. They die from trauma and accidents, and they die from suicide. Many reasons for these patients to die. So here's this same study. This graph just illustrates the 30 days after the non-fatal overdose. You can see day number 2 has significant risk of death. And 20% of those patients that died within the year died within that first month. Important study for sure. So let's see what happens. This is still Massachusetts. This is in the Annals of Internal Medicine. They also looked at similar data sets over similar years retrospectively. In their data set, 807 patients died. Died within those 12 months. 368 of them of an overdose. Basically, 50% of those died. And out of the people that had non-fatal overdose, within that 12 months, only 30% of them received medication for opioid use disorder, meaning methadone or buprenorphine after the overdose in a whole year. And again, remember, this is Massachusetts. This is a state that really is among the leaders in this area. Of course, it's a decade ago now, but when they looked at that 30% of patients that did get medication, the reduction in mortality was 50%. 50%. And it's just, we don't do much in medicine that decreases mortality by 50%. So you can make a big, big impact. As Katie said, you can give them a gift. So this is mortality ratio. This is primarily European data, but it's remarkable. They had a huge overdose crisis in France in the 90s, and buprenorphine and methadone really were pushed out, and the overdose risks just plummeted. You can see the rates of people with opioid use disorder on medication approaches the mortality ratio of the general population. And here I'd like to just talk a little bit about buprenorphine and how it works. This is probably a review for most of you, but I think it's important to know really how buprenorphine works. I do want to sort of say, sometimes I sound like I'm a buprenorphine sales rep because the medication is so effective and unique in its pharmacology. So I assure you that I'm not, but buprenorphine works really because it has three properties. The first property is that it's a partial agonist. It doesn't fully stimulate the receptor. So these patients that are opioid dependent do not get intoxicated from buprenorphine. It's a partial agonist. And you can see the blue line on the graph, it's got what we call a ceiling effect. So once those receptors are saturated, more buprenorphine doesn't cause any more opioid effect. So if you take 5 of your Suboxones, you're going to get no more effect than if you take your normal dose. So it really, less respiratory depression, less sedation. And interestingly, the second key factor about buprenorphine is that despite it's only a partial agonist, but it has a high affinity for the receptor. You know, I tell my patients it sticks in your receptor like glue or gum. And the importance of that is because if you're on buprenorphine, those receptors are locked with buprenorphine and they're unavailable for anything else. So they're unavailable for a full agonist opioid like fentanyl or heroin or the rest of them. So in that way, it protects from overdose. In addition, it's important for the patient to know that, like, oh, that's pretty cool. So when the patient leaves the house in the morning, they know no matter who they run into, no matter what happens that day, there's no sense using because your receptors are unavailable. And finally, the third key factor about buprenorphine is it's got a long half-life, 24 to 36 hours. So it's really in your system. It's on those receptors for several days. So the patients, even if they run into somebody that they used to hook up with and use with, they can't do it that day. They can't do it the next day. They'd have to wait 3 days. And hopefully if they are in treatment, if they're getting the support that they need, they will not wait 3 days and not take their medication to use. They will go to a meeting, take a walk, call a sober friend. And so it's really those three things that make buprenorphine an outstanding medication for opioid use disorder. I love this slide. Think of the white line as dopamine. The sort of the final common pathway of all these addictions is dopamine, and high levels of dopamine make us feel good and give us energy and euphoria and so forth. So the blue is normal dopamine levels. You use opioid and the dopamine levels spike. You feel great. Oh my gosh, that was amazing. And then the dopamine levels fall back to normal. So everything's okay. Then you use again. You're still normal until that whole time, though, as you're using, your brain is making adjustments. It's trying to maintain homeostasis. So during those periods of high dopamine, your brain is saying, whoa, that's way too much dopamine. So it's down regulating that whole system. So it's making less receptors. The receptors are less responsive, less dopamine. So at some point, everybody's different, depends on the use and what opioid, but probably around a month or maybe 2 months, when you don't use, your dopamine levels now fall below normal, and that's withdrawal. And that is very, distressing to people. Of course, we all know about the goosebumps and sweats and chills and diarrhea, but even more bothersome to these patients is the dysphoria, just tremendous despair. Their amygdala is going crazy. It's just very traumatic for them. So then they have to use an opioid just to get back into the normal range. So then you're kind of stuck. Then in order to get dopamine to just raise your kids or go to work or live, you have to have an opioid. So that's it's very, and then it just spirals out of control. And the way that the medication for opioid use disorder works is it gets you back to the blue. Methadone and buprenorphine, they get you back to the blue, and then you feel better. You're not intoxicated, and then you can work on getting your life back. You can work on your relationships, work on your job, go to counseling, get your depression and anxiety worked on, and then get better. And without it, it's very difficult to stay in recovery when your dopamine levels are low and you're in sort of a constant low dopamine state, depressed state. All right, so let's brag on Illinois a little bit. So this is the State of Illinois Overdose Action Plan, or the SOAP. Came out just over a year ago. It's an excellent document. We should all be proud. It has 25 priorities listed in this document around prevention, access to care, equity, criminal justice, and look at priority number 10. Number 10 out of 25, increase initiation of buprenorphine in emergency departments for people who present with opioid overdoses or acute withdrawal. So there it is. Those are the public health people of the state of Illinois asking us to do this. So let's go ahead and do it. So, and there's robust evidence that it actually works. This is really a landmark study in this area. This is emergency department initiated buprenorphine naloxone treatment for opioid dependence, randomized trial. Let's take a look at what they did. So they randomized about 330 patients into 3 groups. Group number 1 basically just got a referral, kind of what most emergency departments do now. Here's a list of clinics. They went a little bit further. They checked with insurance and made sure that they would take their insurance. So it was a decent referral, but nothing else besides a referral. Group number 2 got the referral, but they also got what they call a brief negotiated interview, which was a mental health professional sitting down and talking to the patient and exploring their use and trying to foster change talk and motivational interviewing and so forth. So group number 2 got that. And finally, group number 3 got both of those plus buprenorphine. And you can see in the third group, 89 of 114, that's almost 80% of the patients, the endpoint was receiving formal addiction treatment on the 30th day. So these patients, 80% of them were still in treatment at 30 days. And you may say, still in treatment, big deal. Like, were they still using? It is a big deal. Retention and treatment is an indirect measure of patients that are doing well. They're doing well. It may be bumpy. They may not be doing perfect, but they are engaged. They're showing up for appointments. They're going to the doctor. They're getting their script. They're going to therapy. They are engaged in treatment. And those patients that continue to stay engaged in treatment do well. So the fact that 80% of them were still engaged in treatment at 30 days is a really, really big finding. And look at that study. That was April 28th, 2015. So that's more than 8 years ago now. It's more than 8 years ago now. So it's time to get going. And support is available. That is what we're preaching here. Just to go through these resources, PCSS is Providers Clinical Support System. It's pcsnow.org. Wonderful, federally funded. Webinars, podcasts, experts. You can actually get a mentor through PCSS. It's fantastic. California Bridge is in California, but now they're just referred to as Bridge because they want to advance to other states. They're killing it. So more than 200 ERs in California have programs such as these, and their goal is to get all California hospitals doing this with by 2025 or in the year of 2025. So that's more than 500 hospitals. And I really think that Illinois is poised to get all of our hospitals done probably in the same time frame, a couple of years, because we don't have 500 ERs. We have, I think, a little more than 100. So I think that is absolutely attainable. Yale has been a leader in this area for years. They have a wonderful website with lots of protocols and algorithms. I'm not going to jump into that dosing of buprenorphine, etc. That's going to be webinar number 3, where we're going to kind of dive into that. So you won't hear me talk about the COWS score and precipitated withdrawal and things like that. So, and in the middle there, that's Nick Chen, and he might be on this call. Shout out to Nick. He is a addiction doc and ER doc at Rush, and I know he's passionate about this as well, and will help us move forward in Illinois. But that's Nick starring as the ER doc in a toolkit within the helpline. If you go to the Illinois helpline, you can have access to those toolkits, and Nick will teach you how to start patients on buprenorphine. And finally, SAMHSA has an excellent handout as well. That's about 1.5 years old. Really, tons of resources, you guys. And let's not forget about ACEP, the American College of Emergency Physicians, also has really leaned into this issue, and they have tons of resources on their website. All right, so why am I so optimistic about Illinois? And this is really the reason. These are the game changers here that they're all coming together. So the X waiver is gone. You guys probably are aware of that. That happened at the end of 2022. It's been more than 6 months now. So you don't have to apply through the SAMHSA website. They don't have to send your information to the DEA, and then there's none of that. There's no training requirement. So if you have a DEA certificate, you are able to write for buprenorphine. It's about time. I've already talked about the safety of this medication, so there is no waiver. The Illinois DOP program, or Drug Overdose Prevention Program, that has been around for several years now. And that is a program that allows you to get free naloxone sent to your hospital or clinic or community program at no cost to you. And it's very easy. We'll talk a bit more about that. And finally, the Illinois MAR Now program stands for Medication Assisted Recovery Now. So this is new. This is the new and the most exciting development. So in May of 2022, this was piloted in Cook County only. And then in September, it went statewide. And it's been a dramatic success. I just know a little bit of the data that patients that are call the MAR Now number, their follow-up rate with a community provider is in the neighborhood of 90%. Really, and we'll talk a little bit more about that. So here's the DOP program. So this is the website, Department of Human Services. If you just Googled Illinois DOP program, this would come up. And in essence, if you're a hospital or clinic, you click one tab. If you're a community organization, a library, a domestic violence shelter, a homeless shelter, and anybody who wants Narcan can get it. In essence, it takes about 5 minutes to fill out a Survey Monkey, and then you get Narcan when you want it. You can order it and then you dispense it. There's a little bit of a reporting requirement, but it's really, really easy. And here's the MAR Now program. This is the phone number. So this is 24/7, 365. So patients can call this If they need buprenorphine, buprenorphine can be sent to the pharmacy through a telemedicine visit. Generally, it's about a 1 week supply. And not only do they get the buprenorphine, the care coordinators at MAR now arrange for follow-up. So they do the case management. They will find the patient community follow-up. And that oftentimes is a barrier in emergency departments, especially at 2 a.m. There's no social worker, there's no case manager, but there is MAR Now. So you could call MAR Now from the ER. You could give the number to the patient to call in the morning if you're going to give them a script for 7 days. So lots of ERs calling MAR Now, lots of jails calling MAR Now, frankly. And it's really been a success. Excited about it. All right, so here are the 3 essentials. Take home naloxone, initiate buprenorphine, and connect to a community provider, or through MAR Now or otherwise. Those are the things that we are trying to implement at all ERs in Illinois. So I'm just going to step back a little bit and talk a little bit about addiction. What is it? How do you diagnose it? I know that an ER crowd doesn't need to dive deep into this area, but I just want to touch on it. So I like this definition of addiction. This is from the American Society of Addiction Medicine. Addiction is a treatable chronic medical disease involving complex interactions among circuits, genetics, environment, and life experiences. People with addiction use substances or engage in behaviors that are compulsive and continue despite harmful consequences. Furthermore, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And that was new to me when I started to study addiction. From the ER, you get jaded. You think these patients are not going to get better. They're not going to get better. I see them every week. They get better. I'm here to tell you they really get better. All you have to do is treat them. And how is it diagnosed? So this is the DSM-5 criteria for substance use disorder. I'm not going to go through them one by one. There are 11 of them. I would just comment on at the bottom there, tolerance and withdrawal, of course, are physiologic criteria. And you can't only have tolerance and withdrawal and be diagnosed with substance use disorder. If you've been on Norco for 10 years and you run out and you get withdrawal symptoms, that's not addiction. You have to have more than just those 2 physiologic criteria. So it's easy if you have a total of 3 or less, that's mild substance use disorder. If you have 4 or 5, that's moderate substance use disorder. And if you have 6 or more, that's severe substance use disorder. So the patients that we're generally talking about in the emergency department that we're trying to get you to start buprenorphine on ASAP, usually a pretty easy diagnosis. You'll easily get to 6 of these criteria. Those patients have severe opioid use disorder. So, or rather than memorize all of those, I often just remember the 3 C's. These are patients that have lost control. They have cravings and compulsions and consequences. The 3 C's of substance use disorder. So, and what are the risk factors for substance use disorder? Interestingly, it's sort of the risk factors for other chronic diseases. There's a genetic component, there's an environmental component, there's a behavioral component. And just like diabetes, hypertension, depression. There's also, in the last couple of decades, there's been a lot of work in something you may read about, an ACE score or an adverse childhood experience score. There are 10 criteria: a divorce, poor schools, prison, someone in your family went to prison, drug use in the home. 10 of them. The more that you have, the more at risk you are at developing substance use disorder. But in essence, it's a combination of the factors that are part of other chronic disease development as well, and responds to treatment just as well. So we have been doing this work nationally for a little while, for a few years. So there have been a couple of studies that have looked at how are we doing? Are we making a dent? And so about a year ago, I think it was April of 2022, 2 studies were published in the Annals of Emergency Medicine looking at how we were doing. And the results are not great. So the first one is naloxone and buprenorphine prescribing following non-fatal opioid overdose. So this study looked nationwide. There were about 150,000 non-fatal overdoses. And out of those 150,000 overdoses, only 7.5% got naloxone and 8.5% got buprenorphine. And so it wasn't a lot of patients. Those are pretty low numbers, I would say. And they're probably even lower than that because in this study, you were judged to have gotten naloxone or gotten buprenorphine if you received it within 30 days of your ER visit. So it's probably even less than that. So I think we can all agree that there's some room for improvement there. Same issue, the Annals of Emergency Medicine last year. I like this study, subsequent buprenorphine treatment following emergency physician buprenorphine fill. So there are pharmacy databases out there that are enormous. And so they were able to dive into this nationwide pharmacy database and find out prescriptions for buprenorphine that were written for ED doctors. And they were able, some ER doctors, me included, before sort of moonlight in addiction, they were able to ascertain whether they were given while in the ED. And so they were, I'm sorry, it's covered for me. So 23,000 buprenorphine prescriptions were written. Most of these were in metropolitan areas, and 28.5% of those patients that were written for buprenorphine had a subsequent script written within 30 days. So that sort of, and 28.5, it seems it's not 18, I think, but I think it should be higher. And I think that what that speaks to is sort of the lack of good warm handoff processes. So, it just, that is one of the things that really needs to be dialed in, that community providers need to reach out to emergency departments and vice versa and get a system together that works and that patients can rely on, because only 28.5% of patients getting another buprenorphine script is too low. Okay, so an emergency department opioid use disorder program, what can it do? What are the benefits? So of course it saves lives. We talked about that. It decreases length of stay. I didn't talk a lot about that. The data is not overwhelming, but it certainly doesn't prolong length of stay. And why would that be? I think the main reason is that these patients feel better after getting buprenorphine and feel better quickly. Their withdrawal gets significantly better. So they don't need IVs and they stop vomiting. They're easier to manage. So these patients don't need IVs, they need buprenorphine. So generally speaking, their length of stay is not longer. And ERs that kind of have this down and have been doing this for a long time, these patients, unless they were an overdose, these patients go to fast track. They go to fast track. All of the mid-level providers are comfortable with buprenorphine. They give them buprenorphine. They plug them in with case management. They get a recovery coach or whatever the program has, and they discharge them. So they can really streamline this process. And then the community starts to know about it, and everybody benefits. It decreases return visits. It's cost effective. Again, I didn't jump into there's not a ton of studies on those, but there are a couple. We get paid to do it. There's a procedure code that recently was enacted, and you'll find out more about that in webinar number 4. So, and it increases patient and staff satisfaction. Again, a patient that feels better and is not puking is happy. The staff that made the patient improve is happy. And that over time decreases stigma within the department. As we all know, the stigma can be brutal in the emergency department. But as you start to treat these patients and they get better, and then they don't keep coming back, and then these robust programs are able to give follow-up. So the outpatient clinic says, hey, that guy that overdosed 4 times last month, he's killing it. He's got his job back. He's got his family back. He's working. So bringing those real life stories back into ED department meetings and nursing meetings and huddles can go a long, long way. So it's all good stuff. But if these reasons aren't enough, the lawyers are coming. It's plain and simple. I don't lead with this slide, but I think that this is where we're headed. So this is a pretty provocative paper or a memo from the Legal Action Center. It's about 1.5 years old now, and emergency hospitals are violating federal law by denying required care for substance use disorders in emergency departments. So I think that if you want to peruse this, it's easily attainable. I would also give it to your risk department. They should be aware of it. I think that most people would agree that the standard of care is shifting here. I think that patients that repeatedly come to the emergency department with overdose and aren't offered buprenorphine and aren't dispensed naloxone, I think in the very near future, I think that's going to be challenged. I think that's going to be challenged. There's no X waiver required. People are doing this. The data is clear. All those position statements and the American College of Emergency Physicians recommendations. So we're definitely heading here. And I hope I've been able to stress how easy it is. Like the things that we do in the ER, that there are so many things that are not easy. Door to balloon and door to needle, all these things that are timed and take other departments to help, and sepsis and 30 cc's per kilo and antibiotics and everything's hurry. This is none of that. There's no pressure. It's just prescribe a safe medication, give naloxone, and arrange for follow-up. So let's see what successful treatment looks like.
I'm 51 and I started when I was 12, and this is the easiest time that I have ever had in my life trying to stay clean and sober, ever. And that's a pretty big deal.
Yeah, well, dude, it was a miracle at first, because I was able to go to work while I was trying to get clean, to live life, actually, not alone, just work, just get out of bed, do laundry, whatever, live life. So it was a miracle in that sense.
We were able to buy a house that we never had before. So yeah, life is great. There's bad days for sure, but I don't have to use over them anymore. I know how to deal with it.
Okay. All right. Well, I'm happy to take any questions. Sam, is there anything in the chat?
Yes, our first question, and everyone feel free to keep asking questions in the chat or in the Q&A section. Our first question is from Michelle. There are so many emergency rooms in our area that do not provide detox. Therefore, we have to send them out of county for care. We have limited options for people to get appropriate care. Is there a list of hospitals that follows this protocol that we can see?
So detox from opioids and only opioids generally does not require sort of admission. This is an outpatient. This is easily treated with buprenorphine. Now, with alcohol and benzos, that's a bit more complicated. Those patients really should be admitted medically. So, but I do think if an ER does have a buprenorphine program, there's really no reason to look for a detox bed for opioid detox, unless, of course, complicated social situations and so forth can complicate that decision. But yeah, I would love for my colleagues, Diana and Jess, to comment.
Could I jump in? This is Alyssa, and I'd just like to jump in and say that's where the MAR Now program comes in. Like the hospital can call MAR Now and get the person into treatment. They do not have to have a whole program of buprenorphine initiation. That MAR Now operates statewide. And so that's another opportunity for hospitals to be able to get folks into treatment without right away. Like they could start using that now. I think that's correct, Stephen. Correct me if I'm wrong.
It is correct. It is correct.
And then Diana or Jess, if you have anything else to add.
Detoxification really is not something that for opioids that we really want to have done. Simple detoxification, we really want to start the buprenorphine. And again, the MAR Now number can be very helpful if a specific hospital is not going to, do an induction or start the buprenorphine for the patient while they're the captive audience. The MAR Now number is not only for hospitals to use, but it's for patients to use too. So if a patient maybe is not ready for recovery right now when they come to your ED because they're just not ready, being able to provide them with that number for when they are ready is really helpful, that they know that there's people out there that want to help and that can help and can quickly help is a really important thing.
Any other questions?
Yes.
Sam?
Our next question is, can you say something about treatment options with patients who are recently treated with methadone?
So that's of course a tricky one. We're all smiling. So the going from buprenorphine to methadone is easy. If the patient's not doing well on buprenorphine, send them to the methadone, they can take a dose of methadone that day. However, the converse is not true. And so if you're on methadone, the buprenorphine, remember the high affinity, it can displace the methadone. So it makes that transition trickier. So it can be done. I do it not infrequently at a residential facility, but you have to be sort of careful because that patient can go into precipitated withdrawal as the buprenorphine is kicking off the methadone. So it's sort of a complicated issue that we all deal with, and it can take quite some time to come down on methadone and then going up on buprenorphine. So, but it can be done. It's best done if you read the books. It's best done if your methadone is tapered down to a low dose, and then slowly transferred to buprenorphine. There's also something that you'll read about called microdosing. So you're taking the full agonist, which can include methadone, and slowly building up the dose of buprenorphine, taking very small doses of buprenorphine, and then increasing the dose of buprenorphine over a week or two, and slowly letting that buprenorphine hit those receptors. Jess and Diana, I'd be happy to deflect.
It's a very complicated transition. It is doable. And if you find yourself that you need an answer quickly, you're kind of backed into a corner. California Bridge Clinic has great protocols on how to do it. or if you're nervous about it, really step-by-step, like recipe protocols on how to transition them. And don't be afraid of precipitating someone if you do. We can get through that too. That shouldn't be a fear for starting buprenorphine, the fear of precipitation. I think all three of us have precipitated people before. You'll get through it.
Yep, exactly. And I didn't talk a lot about methadone because it's not really an ER medication for opioid use disorder, because there are strict regulations. There are some ERs where the methadone clinic is actually on the ER, on the campus of the hospital. But I don't know if we have any of those in Illinois. But I think you're going to see some change in that. I think everybody's looking at, why is methadone so regulated? So there's a push to sort of like, what about if an addiction doctor in his office writes for methadone and the patient goes to the pharmacy and gets their methadone? Seems reasonable. So all sorts of things like these you're going to start to see talked about and studied.
And for upcoming webinars, we'll talk a little bit about methadone. So please register for our upcoming webinars that follow this webinar.
All right. Anything else?
Yes, one other question that we had was, how do you collaborate with more ED professionals in order to provide best practices to participants?
You're looking at it.
I was like, that's a good question. And I see Steve's face, because it's you know, it's knocking on the doors and doing things like this. And if you guys have places that you think we should go, or people that we should hook up into, so that we can give more of this education, I think all of us would love to hear about it. We keep going and keep having collaboratives, and we're lucky to be part of Illinois Public Health Institute that keeps this word out there and keeps us out there to kind of keep talking. So that is, that's how we're doing it as much as we can. And Steve works through his affiliation with the American College of Emergency Room Medicine. Anything else you guys can think of how we're doing this?
Yeah, we think that it's best if you can identify and develop a champion, and the champion doesn't have to be a doc. It can be a mid-level or somebody with street cred within the department that is like, okay, I get it. I'm going to be the champion in this ER, and then recruit a small little cadre of people, maybe a nurse, maybe a case manager, pharmacist is always good. And you can just be a team of 3 or 4 people that sort of move this forward within your department. It doesn't have to be huge. It doesn't have to be the STEMI committee or the sepsis committee and blah, blah, blah. It doesn't have to be minutes, just people that are dedicated to this population of vulnerable people and want to move it forward in your department.
Wonderful. And I think that is all of our questions for today.
We were able to buy a house.
Sorry,
it was a miracle
sorry.
first, because
Awesome. So thank you everyone for participating in today's webinar. If you are obtaining physician CME credit, feel free to follow the instructions or click the QR code. We'll be sending up a follow-up email as well. This is through UIC, so you'll have to go to that link, participate in the activity evaluation form, and then once you do the evaluation, you'll get your certificate of completion, and make sure that you enter the enrollment key to do that, which is webinar 1. Pretty straightforward there. So if you'd like to get CME credits for physicians, please do it that way. And next slide. This is what your certificate of completion will look like, certified from the University of Illinois at Chicago College of Medicine. And next slide. So I want to thank everyone. Thank you to our presenter, Dr. Holtzberg, and our supporting subject matter experts, Dr. Batari and Dr. Richardson. They will also be leading some of our next webinars. Dr. Richardson will be presenting next Friday, same time, 100 Wasted Years, Overcoming Stigma and Bias in Opioid Treatment. And Dr. Batari will be presenting on July 14th and July 25th. All the technical detail you need to know, dosing, risk, readiness, and other. And on the 25th, successful collaboration, referral workflows, and payment. So all of those will also have 1 CME credit. So please share with your friends, with your colleagues, with your supervisors, with your CMOs, all of those folks. We'd love for folks to come and participate and learn more about this work. Any last parting words, Dr. Holtzford?
I don't think so. Thank you all for attending, and yes, spread the word.